phone?
Yeah, absolutely. I'm the only one allowed because I have to check Twitter for questions throughout this thing. All right. So yeah, you're generally overdressed, but you're in charge, so you can do whatever you want. But welcome everybody to our live cast for this week. It is September 23rd, and we are 7 days and 14 hours away from ICD-10. That's official.
I'm looking forward to it.
Yeah, just over a week.
Yeah.
Over a week. Month away from my wedding, which is nice. I don't know
Not focused on that. I'm not focused on that, but
yeah. Well, you should be for our clients' sake. That's what I'm worried about. I'm honestly one of the things I want to cover today is there's really 10 things that I've been hearing as reasons for making this change, and some of it I think is total BS coming from CMS and I mean just total BS. But the first thing is, I mean, when we get started here, one of the first things that came up was improving objective quality. ICD-10's goal is to improve objective quality. Have you heard that before, Jason? Yeah. And in what context? Is that just with clients or?
No, actually, I've sat in on CMS webinars. I've sat in on some coding companies who have purchased, the access to their webinars, just hearing what other experts are around the country have been saying, and it's still vague. I don't necessarily have my head completely wrapped around how that's going to be useful to an insurance company. I mean, if you're doing any sort of medical research, making sure you're speaking the same terms makes all the sense in the world to me.
Right.
But, for our intents and purposes, proving medical necessity is what really diagnosis codes are about.
Right.
That's what we're about. So the one thing about ICD-10 codes that really can help is now you've got a severity attached to them.
Right. And
that can improve objective quality. But again, is everyone, if I was to ask you two to rate something from 1 to 10, if I was to, hit you in the knee with a hammer at the same exact, force, I'm sure you would come up with slightly different numbers. And I don't know how useful those severities will be over time.
But I think, I think it's a good idea. And by the way, for anybody watching who hasn't seen past ones, this is Jason, Chief Operating Officer at POI, and Yuval, who's CEO. And I'm Ruben, and I work here. So basically, what we're going to be talking about, the second thing is, I wanted to go over briefly ICD-10, just the structure, because I don't know that everybody knows specifically what goes into each of these fields, and there are up to 7 of them. And I mean, the category, I think, isn't too complicated. I mean, that seems like a pretty arbitrary, like we just want to be able to categorize diagnosis codes, right?
Yep.
I mean, this is a shoulder problem. This is, whatever.
Laterality is determined there, left or right.
Well, and that's where these get interesting, because now you need to talk about etiology, right? Where is the problem? What part of where is the problem is the problem?
Yeah.
And then, of course, is there like an extension, right? Is there something, do we need to get even more specific on it? And I wonder, with improving objective quality, if the goal there is to understand, is for an insurance company to understand better what's actually wrong with the patient. But isn't that what notes are for?
Notes do that, but let's just talk ICD-9 for a second.
Yeah.
With ICD-9, if you wanted to prove laterality, you had to put a modifier in there.
Right.
And I don't know how that wouldn't work, right? But now you're taking a 5-digit code and you're extending it to 7 digits anyway.
Right.
So 6 one, half dozen the other. If you're trying to talk about any of these other things, ICD-9, what it lacked compared to ICD-10 was specificity in how severe something was. That's really every single thing I've written is trying to figure out how bad something in ICD-9 is in ICD-10. That's the real translation. Now, let's just talk about a couple of the one-on-one codes. For a lot of our clients out there, 739.1 cervicalgia, right, has one ICD-10 code. That's it. And it's one of the top 5 ICD-9 codes that our clients have built out over the last year.
Sure.
I mean, and not by a small margin. I mean, it's a big one.
Right.
But then you look at anything in the cervix, the lumbar, the thoracic, you're talking about kyphosis, anything else, Now you're talking about an expansion of one code with a possible, 2 or 3 modifiers to 300, 350.
And that's an incredible thing, because one of the things, and I'm interested in your take on this, because the second top of the top 10 reasons is the goal of ICD-10 is to reduce coding errors. One of the top 10 goals of ICD-10 is to actually reduce coding errors. Yeah. But I'm thinking just objectively, like, how do you reduce the chance of making a mistake on something by increasing the possible choices? Doesn't that not make sense? I mean, just math.
Sounds like a conflict.
It sounds like, right?
Well, you just said
how do you
well, you just said that's what the notes are for. But if you move on to, from something like cervicalgia to anything in the cervix, the lumbar, the thorax, now you've got a whole bunch of specific locations. All right, now you're able to get into specific locations and then talk about, the severity of it. So now you've increased specificity, which again requires any of the physicians or coding experts out there to learn much more in the way of how many codes could actually apply.
Right? Doesn't that make sense though? I mean, when you're trying to reduce coding errors, the goal, I think, would be to reduce the possible choices, not increase them, right?
Yeah, but you can't reduce the number of possible choices because there are
over time there are more.
There are nature processes that are taking place regardless of what we do with ICD-10. ICD-10 is just a reflection of where we are on overall evolution. In 1900, our expectancy of life was 47 years. Today, our expectancy is 77. So if you think 500 years ago, the number of choices that we could die of was rather limited.
Plague and war. I can't imagine anything else, really.
In the middle of 19th century, when they actually came up with the first classification of diseases, it had a list of 129.
Right.
That was it. So there was enough 3 digits to encode every possible cause.
And it's not hard to keep track of the codes that you need to know out of 129. I mean, that's not a problem.
Yeah. So in the middle of 20th century, our life expectancy was already over 60, and we needed 5 codes to manage something like ICD-9. So as the number of diseases grows, we need more codes, and so ICD-10 is one reflection of that, as a reflection of this thing. The second thing that is happening is our ability to process all this information. 150 years ago, you could do all of this manually. You could also enter all those codes in a morgue while examining the body.
Right.
So in other words, in central locations.
Yeah, you have a broken leg back then. Well, this is the end. Write your will. There's nothing we can do. It's going to get infected and.
Right. Today, when we have 68,000 codes.
Right.
In ICD-10, you cannot imagine setting up central code entry facilities. Those would be prohibitively expensive.
Information sharing was enormously challenging.
Right.
Yeah.
So this coding can only be feasible if physicians themselves can enter them. And that's, I think, what they mean when they talk about reduction of errors, because the physician who diagnoses the problem and then treats it, she is in the best position to determine. So basically, we eliminate a intermediary link where there was a coder who translated physician's notes.
Right, now it's more direct.
Now we expect the physician to actually know much more about coding and be able to enter the codes directly, and by doing so, eliminate the errors.
This is interesting because ICD-10 has been adopted overseas already.
ICD-11 has been adopted.
ICD-11 has been adopted. Now, I'm curious about that, because obviously that means that they're even further along. But how were they able to adopt such a complex system where the clinician now needs to be so much more involved in coding without clearly having an interrupt in patient flow? I mean, the clinician needs to step back and learn this, right?
I actually don't know how to answer that one. The only guess I could take here is that they don't have the insurance company burdens that we have over here. In a lot of the foreign countries, the centralized payers make things a lot more simple, right?
Yeah.
So over here, with the myriad or the spectrum of payers that we have to deal with, you have to get a lot more people on board.
Right.
And so, for instance, for us, we can't submit it directly in Minnesota to Blue Cross Blue Shield. There's one organization that has a contract to do that. And you have to go through that organization in order to submit claims for our providers.
Right.
And there are hundreds, thousands even of those organizations. Now you've got to get all those people on
Those
board
TPAs.
at the same time. Yeah.
Yeah.
I think if you compare domestic processing capabilities with overseas, you have to kind of look also at the expectations. And if your expectations are low, it's easy to centralize things and simplify things. So if life expectancy is below 60 years, like in Soviet Union, in Russia, then
Today?
Yeah, absolutely.
Still?
Oh, even worse probably.
Oh, okay. I
So-
assumed that maybe things got
It
better.
caught up a little bit.
Yeah. They westernized a little bit, I thought.
Yeah, some,
Have medicine.
but that's
But they got McDonald's.
the
That didn't
life
help.
expectancy.
Yeah, that's true. They did get McDonald's. That probably made things worse.
So
Unless they're going to
so
sponsor
yeah,
us,
so
in
you
which
can
case-
simplify things and
Just
reduce
kidding.
the number of causes and expect the physicians to behave all the same. Should
Sure.
also expect that physicians make all the same.
Yeah.
So here the expectation for the service quality is much higher, and the expectations for responsiveness is much higher. And so some things take longer to implement.
Yeah.
But once they are implemented, they are actually implemented on a higher level, on a higher technological level. And so it is easier to implement them. I mean, today, the state of electronic medical records is much more advanced than it was 10 years ago, let alone 50 years ago.
Sure.
I mean, 60 years ago, there were already electronic medical records implemented on mainframes, exclusively by the way. So here today, you have it accepted almost uniformly. And so, yes, there are difficulties that electronic medical record vendors have to overcome because of the deadlines and so on. But overall, this is a very significant step forward.
Yeah, I think so. I mean, and that brings me to the next really two of the top 10 here, because I think they kind of go hand in hand. The third one is improving pattern analysis, which I guess if you're getting more specific makes sense. You're able to more clearly define patterns, and then improve the ability to identify fraud and abuse.
The fraud and abuse. I mean, when you're talking about ICD-9, we've seen audits, come through for nephrologists, for physical therapists, and the second you have a diagnosis code that you're taking double, triple the time to treat, Medicare knows across thousands and thousands of providers that this diagnosis code only takes 9 visits for you to treat, and you're taking 30.
Right.
Audit. We're
No,
coming after you.
But that can't happen right away, right? I mean, there's going to have to be a space of time where they build that experience with ICD-10.
I'm
right?
glad you brought that up. That's the first year.
Yeah.
Check out the CMS website. It's where they say for the first year, we're going to pay every single code. They said it. And you can see Aetna, United Healthcare. I didn't see a Blue Cross Blue Shield notification for this, but they said they're going to follow suit with CMS.
Right.
And say, we're going to pay for the first year too. And then we're going to wait for Medicare to come out with their list of codes that will be paid. But wait a second, Ruben. Medicare said they're not coming out with a list. They're just going to stop paying
Right.
certain codes.
Yeah.
Okay.
You have to figure it out.
And then you have to figure it out. And so that's where we actually kind of got excited when we heard that, because we are built for that.
Right.
We are built for, with this network, the first time we see a code get unpaid and we work together, we make a couple suggestions, the clinician chooses it, we're able to see which codes are getting paid and then move in real time to adjust ourselves to the ones that are or not getting paid. And if anyone showed up to any of our other training webinars, we actually showed them in great detail how we go about doing that. So I'm excited about that part, because Medicare is not going to hand you the list of, hey, we learned what's going to work now, so here's what you're going to do.
Isn't that kind of a scary proposition, though? I mean, you think about all the practitioners out there that are really scared and are going to make lots of mistakes in the first year and overbill, for example. Medicare is going to pay everything. I mean, think about, for example, and this came up because one of our clients at POI, Billing Precision.
I'm sorry, I have to correct you though.
Go ahead.
I said a year. Medicare did not say a year.
So for as long as it takes for them to figure it out.
As long as it takes for them to figure it out. So anyone watching this should not say it's going to be a year.
Yeah, I'm going to get paid for a year.
They did not give us a time frame. So
Guaranteed salary. Yeah.
On that.
No, but I think it's interesting to point out, because one of our clients, Billing Precision, works with a compliance organization.
Yeah. A couple of them.
A few of them, actually, yeah. But one of them recently, I follow through social media, John Davila, who's a chiropractor, and used to be a prepayment auditor for Blue Cross, I think.
Yeah, Blue Cross Blue Shield.
And he brought up an experience he had where he was working with a practice, and he worked with a biller. I don't know if you've heard this one, but
yeah.
Okay, so he worked with a biller, and he said, basically, you guys are committing fraud here. You need to stop what you're doing and make a change. And she said, I'm just doing what the doctor tells me. It's not up to me. I'm just an employee. I'm just the biller. So finally, a verdict is handed down.
45 months in prison.
And the biller got 45 months in prison. Regardless, I don't even think he mentioned what the clinician got, which is definitely worse, because obviously that's the person who's...
They did. It was a few years, 6 or 7 years, something along those
6 or 7 years in prison. But the biller, the employee, got 45 months in prison and fines, I'm sure. But you imagine, the amount of responsibility that means that you have to have as an employee, as a part of an organization, when you're responsible for that.
Proving medical necessity is what insurance billing is all about, right? Clinicians, they're focused on getting the patient well, but when you're accepting money from a third party, there are requirements, excuse me. And so these requirements just got more stringent. And
right.
Now, the documentation that you need in order to support that code is really what it comes down to. And a shameless plug for Dr. Davila. He works with Billing Precision and actually built very, very specific documentation to support the codes based on his expertise. And
right.
And I've got to see them in action already.
Yeah.
And so there is help out there. We help people choose codes. We've got a great wizard to help them choose which codes map over from their ICD-10 codes.
Right.
But we do not have the expertise, at this point, to tell them which codes they should be choosing.
Right. Which codes may get paid, which codes may not get paid, at what rate. But there's no way for anyone really to know that just yet. I mean, we need to actually get.
That's why I've spent so much time actually looking at this particular topic to see if there was a source of that information. And as of yet, it doesn't exist.
So it's almost like there's this span of time that's unknown just yet. But there's a span of time where the idea of improving fraud and abuse identification is almost suspended, because there's no ICD-10. So it's not like they're able to use old rules.
Yeah.
They can't use anything new. So within that period, I can't imagine anybody doing that, not knowing how long it's going to last. Even people who are okay with committing fraud. But that's
when the first rejections come in, is when we're going to start to know what's happening.
Yeah, and it's hard to know. All right. Next one, improving the tracking and response to public health issues and outbreaks.
That's the original reason for ICD.
That's the original, yeah.
Yeah, people wanted to know when an epidemic is happening and what is the best way of handling it.
Now, that's got to require some amount of cooperation between payers to aggregate that kind of data, right?
Between payers and countries.
And then, well, yeah, and that's a whole other problem. But I mean, just thinking, and the countries at least might have a common interest in not letting their people die, whereas insurance companies have a profit in mind. So, you know, if Blue Cross
A profit in mind.
or
If we're going to keep with the understatements, that's fine. But
we're just kind of passively thinking about making money as an insurance company. Yeah, it's almost like saying that about a pharmaceutical company.
Aetna's doing all right, Ruben.
Yeah,
All right,
Clearly.
doing just fine.
yeah. The costs are low, revenues are high.
Yes.
Yeah, premiums are good.
But I mean, as far as detection is concerned, there's no central repository where all of this is being sent to. ICD-10 will allow for that in a greater capacity, but still, I'm not aware of any central organization. You got the CDC. I don't know where they glean all of their information from, but
Very painfully, I imagine.
I would have to.
Yeah, at great cost. Okay, all right. Well, so it seems like that's just another reason, a continuing reason from all previous versions of ICD to just become more specific and make it easier to detect patterns and make sure public health issues are kept up to date. Okay, and then the next one, this one seems pretty straightforward, incorporating greater specificity and clinical information. I mean, that's kind of the reason, right?
Self-evident.
Self-evident in a number of spaces, right? I mean, how else can you?
It's I like that, you know, as far as it's going to help us with helping doctors, you know, get better information, because now it's not a modifier choice. It's going to be right in the code, which is actually a little bit simpler when it comes to putting together fee schedules, et cetera.
Yeah.
You know,
Well, it's kind of like when they, you know, the next reason really I think speaks to that too is expanding the details for ambulatory and managed care to better understand how to deal with that kind of traffic, especially when you're talking about, you know, emergency care. You know, if you're able to track patterns, you can actually, you know, divert certain situations. You know, you can actually control the flow of incoming patients. I mean, there's a little bit more power there.
Yeah, but no causes. You know.
Yeah.
At this point, you're diagnosing a problem. But I would, you know, if you even look forward to ICD-11, they actually start talking about, and even the talks of ICD-12 of trying to figure out how to coordinate causes for the diagnoses so that you can actually, you know, move into a prevention mode, which, you know, for most of the clients at POI, prevention is their entire
It's a bread and butter.
outlook.
Yeah.
Trying to figure out how to avoid these diagnosis codes moving forward.
Right.
And so ICD-10 is the stepping stone that will get you to those next code levels that could, I think, actually have the real impact on healthcare nationally and globally.
So more codes.
That's the progression.
Yeah, it's always going to
As
be
medical
more.
science gets better and
Right.
we're able to look deeper into cells and figure out what's happened. I'm not doing any of this, but as medical
Well, don't be
professionals,
modest. You've looked in a microscope once or twice in your life. I mean,
medical professionals are
Yeah.
doing that. It gets more complicated, and then it only increases the need for an organization like ours to up the technology and the sophistication to provide tools to assist practices in doing this. And frankly, it's awesome. I love doing it.
yeah. No. I mean, it's an incredible thing. All right. So the next one, and we're down to our last three, our top three. The next one is decreasing the need for supporting documentation with claims. I think this is interesting. Decreasing the need for documentation with claims. In other words, decreasing the need to send your SOAP notes or your encounters, whatever, with a claim.
I think it goes back to those algorithms that track the number of visits or the type of visits or even the money that you're charging for a visit.
Because you can't do that just on the code, right?
Well, it's
Even
more
if it's more specific.
With the severity, you know, if you know you have one diagnosis code with a lower severity, you would expect fewer visits. And if that doctor consistently with that severity level keeps billing out, because keep in mind, another thing that's included in this code is your initial visits, your subsequent visits, your discharge visits.
Right.
It's now tracking the full spectrum of how you're treating them.
I think you nailed this. You hit the nail on the head. Precisely, that's the point here.
Yeah.
As the lengths, the number of digits grows in the code, there is more and more information stored in the ICD code. Some of that information used to be available only in the claim. So now that information, for instance, whether it is the first visit or subsequent visit or so on, is migrating into the code.
Right. Okay.
And
So
now
what
you
used to
don't
have to
need-
require the SOAP note, you can now find in this diagnosis code on the claim.
Some of it, you still need a SOAP note. But
Yeah.
the
Don't
SOAP
stop
note
doing your
is-
notes.
Right. But the
No
SOAP
one's
note-
recommending that.
Right, but the SOAP note is becoming shorter.
Yeah.
Because some of that information is migrating into the code.
I wonder if it's becoming shorter or almost redundant. And I think that's one of the issues that that I've heard a lot about in working with practices is if I, the clinician, now have to spend more time than my biller learning this because I, the clinician, now have to be this specific, how much time am I really going to have to spend with my patients? And if I decide not to do it while I'm in the office, how much time am I going to have with
Quality of life starts
my
going down.
family?
That's the downside of this whole thing, because as a clinician, you have to spend more time now writing codes.
Right.
And since you are compensated for the time you spent with the patient as opposed to for the time that you document the time that you spent with this patient.
Right.
So you are becoming less
Your hour becomes devalued.
efficient.
Well, at least
Right.
it's a good thing that there's a minimum wage now that they are increasing, right?
No, I'm not sure if that humor is landing in the ears of the physicians watching very well.
Thinking to yourself, well, you think to yourself, you know, I spent 20 minutes with my patient or 15 minutes with my patient, now 30 minutes doing my documentation. I mean, that's just painful.
It is. I mean, we need doctors. We need these guys to be at
The
the top
point
of their
here,
game.
right,
Yeah,
and that's where intelligent automation comes in place.
has to.
Using computers in a way that they save you time, they eliminate the unproductive time or reduce documentation time, help you document correctly and quickly so that you remain while meeting all the requirements and so on, but you remain within the profitability margins and even improve them.
Right. I mean, that's one of the
That's
really
key.
the telltales of Vericle as one of our products, where the documentation can pull from visit to visit in such a way that you can make point changes as opposed to writing an entire new note, and the billing as well. The only question I have on the billing side is, as these things get more and more specific to the visit, that might actually end up impacting that speed from visit to visit, no?
Well, it could, but we can develop notifications that help with almost all of that.
Right.
We don't have them developed yet because we're still learning.
Oh, because nobody knows.
Yeah.
I mean, there's no one could know. Yeah.
Yeah, I just wanted to make sure anybody watching doesn't think, hey, I'll go sign up with one of the POI, clients and say they've already got this. As we learn, the system will get smarter and we'll be able to tell you, hey, you didn't put an initial visit in here.
Right.
We're not sending this anywhere for you.
Right.
Choose one of these 3 codes. These are the only 3 options that you have, and let's get this resubmitted. Or, if you've got subsequent visits or, you haven't closed this person out within a certain time frame that we can start learning, we can start helping them do that. So their documentation actually can become less complicated in that aspect because the code contains the
I think that's an important thing, because when you think about not just what we learn as a provider of products and as a cloud-based platform, but also what our clients are doing with the organizations they work with. You think about CBP, PBS, Elevation Health, Maximized Living. I mean, all of these organizations have an interest in making sure that their unique ways of approaching care are covered in these new changes. I mean, those are all things, in my work in Atlanta, talking with Physicians Business Solutions, that was one of the major things is, how are we making the shift into ICD-10 for our clients?
Well, one of those organizations, went in and created very, very specific note macros
Right.
that, take all of the ICD-9s and give them as many of the possibilities as their compliance experts have come in, so that their doctors who are super high volume.
Right.
And let me reiterate, 1,200 visits a week, 1,400 visits a week
Yeah.
with 2 clinicians.
Right.
They can't lose that time. They can't spend extra time searching for this. So they've actually prepared a very nice platform, and they've been working with us very closely to make sure that they don't lose continuity.
But what a great thing to have, that the ability to work hand in hand at the ground level and at the technology level to bring those 2 things together so powerfully. That's great. Okay, top 2. Increasing sensitivity for grouping and reimbursement methods. Increasing sensitivity for grouping and reimbursement methods.
So I don't know if anyone else knows what that means. I don't. All right. I've heard it before. I still don't know what it means.
It's not the first time, and I've heard it from clients and like from practice owners. And like, this is one of the, I need to know what this means. And you're thinking to yourself, increasing sensitivity for the grouping and reimbursement methods. I mean, that to me sounds
Let me give you my translation.
Yeah.
The unofficial.
Yeah.
I get to pay you less.
And I was going to say the same thing. It means that if you try to keep grouping codes together like you have been, I'm going to tell you no. And now you need to figure out a new way to submit your claims, especially if you're an integrated practice.
So one of the changes that happened a few years ago that I hope no clinician listening to this knows anything about, especially if you're one of our clients, we had no problems, but it was a major change. It was the 4010 to 5010 change. I'll give you a 2-second explanation on that. It's a completely different electronic spec or format to submit claims that was universally accepted.
Right.
And it went off without a hitch. We warned that there could be problems, but again, this happened. But what it changed was 4 codes able to be submitted electronically on a HCFA form to 16.
Right.
Okay. So why? Why would you need 16 codes? Because a lot of patients have a lot going on. And medical necessity is never just proven with just one of those codes, but by itself, standing alone. But you put all of these things together, and now the doctor's actually treating a system of problems that are working in concert to debilitate a patient. And so 5010 takes those 16, ICD-10 takes those 16 codes and makes each one of them more specific.
Sure.
So now there is the permutations of combinations of the problems start to grow astronomically and exponentially.
Right.
So when I hear that it's, sensitivity to reimbursements, that's very special and specific language that says, I can now catch a doctor who's overbilling.
Yeah. And especially, I mean, you think about how much more complicated it is. In the past you had, let's say 2 diagnosis or 3 diagnosis codes and 2 or 3 procedures, and you would link them, and that would take all of 5 or 10 seconds. Now you've got 16 procedure codes that you have to link to one of many diagnosis codes. I mean, that's going to be an incredible, especially when you have, for example, an integrated practice with multiple specialties, making sure that, first of all, if you are bundling codes on a claim, that they're actually, because if I'm an insurance company and I'm processing a claim and I'm looking to make a profit, and you send me codes that mix specialties and you don't link them, I'm going to assume you meant the wrong combination so that I can not pay you.
Give you an example. Group therapy versus one-on-one therapy. Those are 2 different CPT codes.
Yeah.
Okay. The severity on a few of the examples that I learned from our compliance experts is if it's a large severity, you can't put someone in group therapy. If it's a low severity, go ahead and put them in group therapy.
Sure.
That's sensitive to reimbursement.
Yeah. Individual care certainly pays a little bit more. All right. And the number 1, improving claim submission efficiency. I mean, and that to me speaks a little bit more towards us as EHRs and practice management systems. My big thing, and the thing that I was saying for a long time, is this thing hits, a lot of these software companies are just going to go under, are just not going to be able to keep up with this change, smaller ones.
I mean, we recently gained a new client here at PY for that reason alone.
Yeah.
Really recently. My expectation is that the clinicians who could be watching this right now, or even a potential new billing company that would come on board, with that, we handled this. They were focused on making sure doctors are trained on how to use the software, making sure they keep growing. We got this. I hate to say it. There are some things that perhaps we haven't seen. We've done all the testing that you can possibly want to do in every single format that you can possibly want to, with all the different linkings, combinations that you can. So our doctors really just need to focus on choosing the right code and making sure they're documenting. Submission's us. That's not their worry.
Right. Yeah, absolutely. Well, there it is. I mean, those are really the top 10. I mean, this is from, the ICD-10 code searching websites. This is from CMS groups and things like that. The top 10 reasons why we're looking at ICD-10 and things. And I imagine that, as this starts rolling out, we're just going to see more pain before it gets better. But at least for a little bit, they'll pay on everything. That's nice.
We've told our staff no vacations in October and November, right?
Sure.
We all have to be here,
Yeah.
geared up. We did the same thing when that 50-10 change happened, and it was a lot of bark, no bite. We don't know what it's going to be like for this one, but I would imagine most of our staff will spend time training and instructing. If there is a technological problem, we've geared up for that as well. But October 1, and I don't know if you have the new official countdown count, but
7 days and 13 hours.
we'll find out. And anybody watching, get in touch with us if you got a concern. We'd love to, talk to you about your individual needs.
Yeah, absolutely. Well, I mean, we're 7 days away. We're a week away, which means that we'll be here next week, actually talking about this on the day that it goes live. So that'll be interesting.
I'll only spare a half hour that day.
Yeah. No, we're gonna be pretty busy, I imagine, that day. But I'll say definitely check that out, because anything that comes up on Go Live will be interesting to talk about. If you haven't already, make sure that you're subscribed so that you keep getting invites to our live casts and any other events, especially since we're going to be traveling a lot more in the coming months to events and things like that.
Right.
A huge welcome, of course, to Elizabeth Thomas, owner of one of our new clients, one of our new billing companies.
Excited to talk to her a few times.
Out in Texas. Very cool.
Yeah.
Very excited about that. If you haven't picked up any of our books, here they are. And I think we're over time, so I can't go into each of them, but they're all great, and you should get them and read them and review them on Amazon. So thanks, guys, and until next week.
Thank you.
Thanks.
I'm gonna go shut this thing off now.
Big week next week.